So welcome to another video on quick revision series. Today will be on pulmonology. So this discussion will be useful for undergraduates for competitive exams like NEET or NSET. So we'll start the basics of pulmonology. So to understand pulmonology, we'll review the cardinal symptoms of pulmonology. So there are 6 cardinal symptoms in respiratory system. One is cough. The next is expectoration. Then we have wheeze, breathing difficulty, chest pain, and hemoptysis. Of these, breathing difficulty and chest pain are common to both cardiovascular system and the respiratory system. So how does the breathing difficulty differ in both? So that we'll discuss, and how does the chest pain differ in both? So we'll discuss one by one. So cough can be due to a problem with the airway, or it could be a problem with the interstitium. So now what we are doing is we are trying to divide the respiratory system into different functional units. So cough may be a problem with the airway, or it may be a problem with the interstitium, or it may be a problem with the parenchyma, lung parenchyma. Expectoration is always a problem with the lung parenchyma. So the lung tissue is involved here. Wheeze is important because wheeze is exclusively a symptom of airway disease. Please remember, wheeze and breathing difficulty are not to be taken together. Wheeze is the whistling sound which is heard during respiration, especially during expiration, whereas breathing difficulty is not so. It's a difficulty in breathing, right? So if there is a whistling sound or if there is a mention of wheeze, it is always a airway disease. So breathing difficulty is difficulty in breathing. So usually they say cardiac breathing difficulty will usually be exertional. But remember, during conditions like pulmonary edema, that is during the acute setup, we cannot differentiate. Whereas respiratory causes, they will be associated with breathing difficulty. There may be associated with other symptoms of respiratory disease, like there may be wheeze, there may be hemoptysis. In addition, this can also occur at the wrist. So this distinction is not very clear cut, but usually in cardiovascular system there will be other cardinal symptoms of CVS, like palpitation, anginal type of chest pain, syncope, etc. Whereas in breathing difficulty due to respiratory system, there will be symptoms of respiratory system like expectoration, cough, and chest pain. That's the hemoptysis. That's usually the way to differentiate breathing difficulty due to CVS and RS. About chest pain, we can think of 2 terms: anginal type of chest pain and pleural type of chest pain. So anginal type of chest pain is one type of cardiac chest pain. So in anginal chest pain, the pain is usually retrosternal. It is compressing type. It occurs or is exacerbated by exertion. Exertion can be exercise or even emotion, and it is relieved by rest or by giving drugs like nitrates. So this is the typical anginal type of chest pain. Of course, chest pain can also occur in respiratory system. That type of pain is usually a pleural type of chest pain. So in pleural type of chest pain, the pain is not retrosternal, it is lateral or in the axillary region. So why it is in the axillary region is pleural type of chest pain occurs in diseases causing pleural inflammation, And pleural inflammation will be causing chest pain when the parietal pleura and visceral pleura rub against each other. So that process is more common in the axillary region. That's why axillary chest pain is more common. So what type of chest pain this is? It is a stabbing type of chest pain. It's a severe stabbing type of chest pain. Anginal pain is a compressing type of chest pain. So what brings about pleural chest pain is anything which causes movement of the chest wall. So like deep breathing or coughing, or sometimes even turning position in the bed. So how is it relieved? When the person does not breathe, the pain will get relieved. So splinting in the sense when they lie to the deceased side, that side of chest wall does not move, right? If you remember, pericarditis is also inflammation of the pericardium. Pericardium is the covering of the heart, like pleura is covering the lungs. So pericardial chest pain also will be similar to pleuritic type of chest pain. Usually in diseases causing pleuritis and pericarditis together, these two types of chest pain will come. Pericarditis chest pain, whereas pericardium, it is close to the retrosternum. So pericarditis pain also will be retrosternal, but it will be like the pleuritic character. It will be stabbing type, and it will be relieved by splinting. So to splint the pericardium, patient has to lean forward. Right. So in cardiovascular system, we can get chest pain either due to the anginal type of chest pain or pericardial type of chest pain. Pericardial type of chest pain is like a pleuritic type of chest pain where there is a particular localization. It is of stabbing quality. It is aggravated by movement and relieved by splinting. So where will we get pleuritic chest pain? In pleural diseases. So again, we are subdividing the respiratory system into multiple parts. So in pleural diseases, we get chest pain. So where do we get hemoptysis? Hemoptysis, again, it can occur anywhere. It may be a parenchymal disease, or it could be an airway disease, or it could be a pulmonary vascular disease. Okay. So here we can clearly see in pleuritic type of chest pain, we will not get hemoptysis. In pleuritic diseases, we will not get hemoptysis. And breathing difficulty also can occur due to any lesion, any place. It could be an airway disease, interstitial disease, or parenchymal disease. Now, cough can be due to airway, interstitial, or parenchymal disease. How will you differentiate cough due to everything? Airway disease, there will be cough with wheeze, with expectoration, with or without hemoptysis. In parenchymal disease, there will be cough, expectoration, with or without hemoptysis, but there will not be wheeze. In interstitial diseases, none of this will be present. So interstitial disease will cause a dry cough. So in discussing together, we have airway diseases. We have pulmonary parenchymal diseases. We have pleural diseases. We have interstitial diseases. And we have pulmonary vascular diseases. So this is just a broad category. Of course, we have extra also, like we have chest wall diseases. Because respiratory system is surrounded by the chest wall also, so they also influence the symptoms of respiratory system. So what are the symptoms of airway? Wheeze is the main symptom. There can be cough. There can be hemoptysis. Expectoration also can be there. Usually it's a mucoid type of expectoration. What is not present? Chest pain is not a symptom of airway disease. And as such, breathing difficulty is not a symptom of airway disease. Pulmonary parenchymal disease, it can cause breathing difficulty. There can be cough with expectoration. There can be hemoptysis. So what is not present? Wheeze is not a symptom of parenchymal disease. And chest pain is again typically not a symptom of parenchymal disease. Plural, the symptom is pleuritic type of chest pain and nothing else. There can be breathing difficulty, but pleuritic chest pain is the main. Interstitial lung disease, there will be dry cough. There won't be wheeze, there won't be expectoration. Pulmonary vascular disease, vascular is blood, so hemoptysis is the main symptom. Breathing difficulty can occur. Chest wall diseases, okay, we will not confuse too much. Now, what are the diseases? So, the entire point of discussing this basic for 10 minutes is, when a scenario is given or when we come across things, we often get confused between different respiratory diseases, how to localize them. So, this may help. So, the airway diseases are bronchial asthma, COPD, bronchiectasis. There are small differences in diagnosis, treatment and pathology that we will discuss subsequently. And example of parenchymal diseases, lung tumors, pneumonia, etc. Pleural diseases, we have pleural effusion, which is fluid accumulation around the pleural cavity, and we have pneumothorax, which is air accumulation in the pleural cavity. All the interstitial diseases are labeled together as interstitial lung disease. It has a very broad classification and discussion, which we will discuss. Example for vascular diseases are pulmonary embolism and pulmonary hypertension. We can also say obstructive sleep apnea as an airway disease also. Okay, so this is a quick revision table for symptom analysis. So that is what is given here. So airway disease comes under a broad category of obstructive airway disease, because airway can only be obstructed. So asthma, COPD, bronchiectasis, bronchiolitis. Bronchiolitis is usually a pediatric condition. There is something called as restrictive pathophysiology. That also we will discuss subsequently. Airway can be obstructed. When there is a disease in parenchyma, it usually restricts the lung. We will discuss that subsequently. So idiopathic pulmonary fibrosis is a type of ILD. Asbestosis is something called as occupational lung disease. DIP and sarcoidosis are also interstitial lung diseases. Then I told you chest wall diseases. So chest wall diseases, neuromuscular diseases also cause restrictive pathophysiology. So all the neuromuscular diseases like amyotrophic lateral sclerosis, GBS, myasthenia gravis, they are chest wall diseases. They prevent expansion of the lung because of the muscle weakness. So they cause something called as restriction. It is called as extrinsic restriction. Whereas the above diseases, interstitial lung disease, etc., they are called as intrinsic restriction, because there is a problem in lung which prevents expansion of the lung itself. So these diseases are called as intrinsic restriction, whereas problems with the chest wall or neuromuscular diseases are called as extrinsic restriction. Even kyphosis, diseases like ankylosing spondylitis, effusions, these are diseases around the lung, so they come under extrinsic restriction. Right? So airway diseases usually are obstructive diseases. Pure lung diseases are called as intrinsic restrictive diseases. Neuromuscular diseases or chest wall diseases are called as extrinsic restriction diseases. So vascular diseases are pulmonary embolism, pulmonary hypertension, pulmonary veno-occlusive disease and vasculitis. They usually cause hemoptysis. And lung malignancy, again it's a pulmonary parenchymal disease. Malignancy is classified in, could be metastatic or it is primary bronchogenic carcinoma. It's of two types, small cell lung cancer and non-small cell lung cancer. Non-small cell lung cancer is of three types. And infections or pneumonia, we'll discuss that also. So this is about the basic symptom analysis and the types. So another basic physiological concept is lung volumes and capacities. So tidal volume is the normal volume of air which is taken in or taken out during a normal inspiration or normal expiration. This is usually 500 ml. So normally we take 500 ml during a normal inspiration. We expire 500 ml during a normal expiration. So this is 500, this is 500, inspiration or expiration. What is inspiratory reserve volume is the amount of air which can be taken on top of the tidal volume during inspiration. So this is the extra amount of air this can be taken beyond the tidal volume. This is called as inspiratory reserve volume. Likewise, we have expiratory reserve volume, that is the amount of air which can be exhaled after a complete tidal expiration. So this extra amount of air which is let out after a normal expiration is called as expiratory reserve volume. But remember, even after exhaling all the possible air from the lungs, some amount of air remains. That is called as residual volume. This concept is very, very important. Now we have something else called as functional residual capacity, FRC. What is this FRC? FRC is the amount of air which remains in the lung after a normal tidal expiration, right? So we do a tidal expiration, how much amount of air is left in the lung is called as functional residual capacity. We do a forced expiration, so after that how much amount of air is left in the lung is called as residual volume. Now what is vital capacity? Vital capacity is very important because we clinically measure that. Vital capacity is a sum of the inspiratory reserve volume, the tidal volume and expiratory reserve volume. So how do you measure it? A person is asked to take a deep inspiration and is asked to expel it completely outside. So this includes this tidal volume, the inspiratory reserve volume and the expiratory reserve volume. Total lung capacity is vital capacity plus the residual volume. So the entire capacity of the lung. So in addition to the vital capacity, what remains in the lung is called as residual volume. So the sum of these two is called as total lung capacity. So the value differs in males and females. Males, the total lung capacity is 6000 ml. Females, it is 4200 ml. These are usually static values. So vital capacity is 500 ml everywhere. If you forget everything also, don't forget the tidal volume. Okay, don't forget tidal volume is 500 ml. And residual volume is 1200 in males and it is 1100 in females. So the tidal volume is similar. Residual volume is also nearly similar. So what differs is the inspiratory reserve volume is 3100 ml in males and 1900 ml in females. That is how the difference comes, because total lung capacity is only 6000 ml in males and 4200 in females. So these are the static volumes and static capacities. We have something called as dynamic volumes. In dynamic volumes, in addition to the volume, we also include a factor of time. For example, all these values and capacity are important while doing a pulmonary function test or a spirometry. In spirometry, what is done is a person is asked to blow or take in air or blow out air into a tube. So that tube and connected to a machine will measure the amount of volume which he exhales. There is something called as FEV1. That is forced expiratory volume. Expiratory volume is the volume which he breathes. The 1 stands for 1 second. Why it is forced? Because he is forcing the air as far as he can. So that is forced expiratory volume in 1 second. This value is very, very important because this is commonly measured and used to interpret diseases. This is used to differentiate obstructive versus restrictive disease during spirometry. So remember the static lung volumes and static capacities, and remember about forced expiratory volume in 1 second. Similarly, we have FVC. FVC is forced vital capacity. Same thing, it is measured with respect to time. So how does it help? We will discuss shortly. So this is flow volume loop. Again, it's a physiological concept, but when it is drawn or when it is given, we can interpret whether the person is having an obstructive lung disease or whether he is having a restrictive lung disease. We can find it out using the flow loop. Usually this flow volume loop is also given during a spirometry report. So volume is measured in the x-axis. Flow is measured in the y-axis. So when the person completes inspiration or completes the expiration, the flow is 0, right? That is why it's in the 0 point. Flow is 0 in the y-axis. Inspiration begins when there is a negative pressure, right? So that's why inspiration is marked below, expiration is marked above. Okay, so inspiration is marked below because inspiration starts when intrathoracic pressure becomes negative. Expiration is marked above because expiration happens when intrathoracic pressure becomes positive. So we start from this point. Okay, so during inspiration what happens? Intrathoracic pressure decreases, so lung volume increases, right? We start from here. The intrathoracic pressure decreases, the volume increases, so and finally it comes and ends here. At the end of inspiration comes. So this point is the peak of inspiration. So a person starts inspiring when the negative pressure comes. When the negative pressure is in the peak, inspiration is in the peak, and when the negative pressure decreases, the flow also starts decreasing, and finally it comes to around this volume, right? So from 0 volume it has come to around this volume. What gap they are given here, that this is the residual volume. So from the volume of the lung has increased to this much. Now at the end of inspiration, person is having this much volume in this lung. Now what happens? He starts expiring. So there is increased flow again, but the volume decreases. So that's why it comes in this direction. So some amount of air comes and finally suddenly flow stops, right? So this is how the normal curve is. But see this curve, there is 0 flow. So person starts inspiring when the chest thoracic pressure becomes negative. The maximum negative pressure is reached, and when the pressure starts decreasing, again still volume keeps on increasing, and finally flow reduces. Now when he tries to expire, see here there is a bend, because we know the normal curve comes like this, right? Whereas in this case, the graph is going a little bit inside. So why it is going like that? It means that the flow is slow. So why the flow is slow? Because there is something obstructing. So this particular graph is the typical feature of obstructive lung disease, because in a normal graph, I will put it in a dotted line, it will come like this, right? So this is how an obstructing lung disease will be. I am not discussing other graphs. You can read it if possible. I will draw another graph for restrictive lung disease. So again the same thing. Expiration is marked above because it is positive. Inspiration is marked below because pressure is negative. And y-axis measures the flow. X-axis measures the volume. So we start from here. Inspiration starts when the pressure becomes negative. The volume keeps on increasing. The pressure reaches a peak. Then pressure starts to fall down. Still flow is there. Again, person starts expiring. So air comes out. Maximum expiratory pressure is reached. Then flow suddenly reduces. Here if you see, I will draw another reference curve. What is marked in blue is the normal flow volume loop. What I marked in green is for a patient. So what disease this patient have? This is usually portrayed in scenarios or questions. So we can see that the graph is or the graph orientation or the graph shape is normal. But only both the inspiration and both the expiration, they are smaller. Which means there is now nothing obstructing exclusively the expiration. Right? There is nothing obstructing the expiration. But the entire lung volumes and capacities are low. So this is an example for a restrictive disease. Right? So in an obstructive disease, inspiration is perfectly normal. Expiration, the peak reaches the normal. Like person will eventually expire all the air during the peak of expiration. But what happens is, in the initial part when he tries to expire, he cannot do it. So this initial part of expiration is what is called as FEV1. That's why we are discussing in spirometry, forced expiratory volume in 1 second is low in obstructive lung diseases. So this is the graphical representation. During expiration, initial part, he cannot expire more. So forced expiratory volume in 1 second will be low. But eventually he will reach the total lung capacity normally. Whereas in restrictive lung diseases, it is not so. Restrictive lung disease, there will not be an initial fall. Like FEV1 will be reduced, but when compared to the forced vital capacity, that is the total air which he is expiring, the ratio will be normal, which means the shape of the flow volume loop will be normal, but compared to a normal person, the entire lung volume is low. So we can see that in obstruction, the forced vital capacity will be normal, because at the end of expiration, they will finally will be able to expire all air. But the volume of air expired in the first second will be normal. So FEV1 by FVC ratio will be reduced in obstructive lung disease. Whereas in restrictive lung disease, compared to a normal person, the air expired in the first second will be low. The amount of air expired in total also will be low. So when taking the ratio, this ratio will be normal. So in restrictive lung diseases, FEV1 by FVC ratio is normal, whereas in obstructive disease, FEV1 by FVC is reduced. How much reduced? We discussed some 3 obstructive lung diseases: bronchial asthma, COPD, bronchiectasis, and obstructive sleep apnea. In bronchial asthma, they are given the criteria: FEV1 by FVC ratio is less than 80%. 80% is 0.80 absolute value. In COPD, FEV1 by FVC ratio is less than 70% or 0.70. Okay, remember these values, we will come to the discussion later. So, filling this differentiating table again, in obstructive lung disease, FEV1 by FVC is reduced. In restrictive lung diseases, FEV1 by FVC is normal. So how will the graph be in obstructive lung diseases? Inspiratory graph will be normal, expiration will show a peak-like structure. How will be the graph in restrictive lung diseases? It will be the normal shape, but compared to the normal graph, it will be reduced. So flow volume loops may be portrayed in scenarios. Now another physiological concept is VQ mismatch. So V is ventilation, Q is perfusion. So just a small anatomical recap. The process of taking in breath has 2 main processes. One is ventilation, another one is exchange. So ventilation is the process by which oxygen is taken in and carbon dioxide is exhaled out. It is just a mechanical process. Okay, the air enters in, the air goes out. Exchange is the oxygen from the alveoli enters into the capillaries, and the carbon dioxide from the capillaries enters into the alveoli. That is exchange. Exchange occurs at the pulmonary, capillary endothelium and alveolar endothelial junction. So that's the terminal part of the alveolus and the capillary. So this region. So this is the alveoli, this is the pulmonary capillaries. This is the place where exchange occurs. Ventilation occurs in the major airways. So this place. So the trachea, bronchus and bronchioles. There are some 23 generations of trachea, right? They say up to the 17th generation of trachea is entirely for conduction of air, and beyond that only exchange occurs. So the place where best exchange occurs is the last part, alveolus and the pulmonary capillaries. Now what is ventilation perfusion mismatch? So air is taken in, but the same air does not get exchanged in the pulmonary capillaries. That is what is ventilation perfusion mismatch. And there is something called the shunt. Shunt is the mechanism where the blood from the pulmonary arteries, that is the deoxygenated from the pulmonary arteries, do not get oxygenated. So the deoxygenated blood enters into the pulmonary veins. So normally the deoxygenated blood comes in the pulmonary artery, exchange happens in the pulmonary capillaries, and oxygenated blood enters into the pulmonary veins. That is what normally happens. But suppose, assume due to some pathology, the blood is not getting oxygenated at the pulmonary capillaries. So deoxygenated blood from the pulmonary artery will now go into the pulmonary veins. So that is called as shunting. So see here, this is the pulmonary veins because the saturation is 75. So this is the pulmonary artery, the deoxygenated blood in the pulmonary artery. So this should get oxygenated and this has to enter the pulmonary veins. But due to some problem here, the oxygenation does not happen. So see this part and see this part. Here, this alveoli is completely blocked. So example for completely blocked alveoli is lung collapse. So assume that right lung is collapsed, left lung is alone functioning, right? So one lung is normal, one lung is abnormal. When the lung collapses, what happens? So assume that this is right lung, okay? Assume that this is right lung, assume that this is left lung. Right lung is completely blocked. So what air is taken in does not reach the alveoli. So of course this blood is not oxygenated. So the blood coming from the right lung is deoxygenated. It is still 75% only. Whereas blood coming from the left lung is normal, so it oxygenates the blood. So blood coming from the left sided pulmonary veins will be 100%. So when these two come, definitely the mixed blood will have a low oxygen saturation. So when lung is completely blocked or when the part of the lung is completely blocked, there will be problems with oxygenation. So deoxygenated blood only enters the pulmonary veins. So the resultant blood will have hypoxia. Now can this be corrected? Because there is a complete occlusion. So even though if you increase the oxygen, that is what is given in this figure. They are giving 100% oxygen. 21% is the normal inspired oxygen in room air. 100% oxygen is they are giving 100% oxygen by mask or a delivery device. In spite of giving that, this oxygen never enters the collapsed right lung. So the same pathology persists despite oxygen. So there is hypoxia in shunt, there is hypoxia which persists even after giving O2. So I think this is something which can clarify your doubts. So there is a lung collapse. So when there is a lung collapse, that part of the lung is not getting oxygenated and that part of the pulmonary arteries or pulmonary circulation will not be oxygenated. So the resultant blood will have hypoxia. That hypoxia will never get corrected despite giving oxygen. So shunt is hypoxia which doesn't get corrected on giving O2. In physiology, many technical terms like dead space, etc. will be discussed. But practically, when a scenario is given, to find out whether there is a shunt, hypoxia which never corrects by O2. Now assume this diagram. There is a partial occlusion here, right? Air is going in, but it's a partial occlusion. So this is a ventilatory disorder or an obstructive airway disease. Assume that this is COPD. Airway is shrunken. So of course air enters here. Air enters the right lung, air enters the left lung. So in the right lung, what happens? Obviously, because of the reduced ventilation, there will be hypoxia here. And this part of the pulmonary circulation, obviously will have a low oxygen saturation, whereas the left lung is oxygenating the blood normally. So the resultant blood is having hypoxia. Same like the first scenario. But what happens on giving 100% oxygen here? Despite being a block there, this oxygen will definitely increase the oxygen concentration of the right lung again, because there is not a complete block. So increasing oxygen concentration will definitely increase the oxygen saturation even in the diseased lung. So this lung is again oxygenating normally, so the resultant combined blood will be normal. So this is an example. So in obstructive diseases or ventilatory disorders like COPD or OSA or bronchial asthma, there is hypoxia, of course. Why hypoxia? There is partial obstruction of the air, so ventilation is reduced, so there is hypoxia. But this gets corrected with O2. So in ventilatory diseases, hypoxia will not be a problem, right? Now another term called as VQ mismatch is used. What is VQ mismatch? What is shunt now? Ventilation is reduced, circulation is normal, so this leads to hypoxia. That hypoxia persists despite O2. So low ventilation but good circulation is shunt. VQ mismatch is the opposite. Ventilation is normal but circulation is affected. I think the same process only happens. That is, ventilation is normal, circulation is abnormal. So definitely there will be hypoxia. So even though we give O2, since the circulation is abnormal, this will not get corrected with supplemental oxygen. So this is the pathogenesis of pulmonary embolism. Right? In pulmonary embolism, there is occlusion of the pulmonary arteries. So the pulmonary capillaries will receive less blood. So since the pulmonary circulation is blocked, the resultant oxygenation will be low. So the pulmonary veins will carry a bit of deoxygenated blood. So the resultant circulation in the aorta will be deoxygenated blood only. The problem here is not ventilation, it is circulation. So this is called as VQ mismatch. That is why in older days VQ scan was used to diagnose pulmonary embolism. So pulmonary embolism is an example for VQ mismatch. Lung collapse or pulmonary effusion, pleural effusion, everything which collapses the lung will cause something called shunt. In shunt, circulation is normal but ventilation is abnormal, right? But in COPD, remember, in ventilatory diseases, there will be hypoxia but it will get corrected with O2. So understand the difference between VQ mismatch and shunt. So this is a pure physiological concept I just brought in to give you the clinical hint. Both in VQ mismatch and in shunt, there will be hypoxia which will not get corrected on giving O2. Whereas in ventilatory diseases like COPD, bronchial asthma, OSA, giving oxygen will improve the O2. This can be given in scenarios. Patient comes with hypoxia, it never improved with O2. Think of a shunt or think of a VQ mismatch. Pulmonary embolism will be more likely. Patient comes with a breathing difficulty, wheeze, there is hypoxia. Patient was given supplemental oxygen. Patient's hypoxia improves. So what this may be, it is not a shunt or VQ mismatch. It may be a ventilatory disorder. Remember, problems with the pulmonary respiratory membrane, that is the problems with the alveolus or problems with the capillary. Whenever exchange is affected, there will be hypoxia, which doesn't get corrected with O2. So till now we discussed few of the tougher concepts. We discussed flow volume loops, we discussed lung volumes and capacities, we discussed FEV1, FEC. So now take some clinical examples. So till now we discussed few terms. We discussed obstruction. Obstruction is an airway disease. There are two important airway diseases. One is bronchial asthma. Another one is COPD. Bronchial asthma is a different pathology. COPD is a different pathology. COPD, there is destruction of the alveoli. Bronchial asthma, there is problem with the airway alone. Okay. And restriction, we discussed two things. Extrinsic restriction restriction and intrinsic restriction. So pulmonary fibrosis is an intrinsic restriction. Chest wall disease is extrinsic restriction. Okay, respiratory muscle weakness is also extrinsic restriction. Okay, so we have restriction and obstruction. So how to differentiate each? So we discussed about the most important factors, FEV1 by FVC ratio, right? So what happens to FEV1 in restrictive diseases? It becomes low, but FVC is also low, right? That is why FEV1 by FVC is normal. So in this side, FEV1 is low, FVC is low. So FEV1 by FVC, this ratio becomes normal. Whereas in the right side, so here in obstructive lung diseases, we discussed FEV1 is the main factor which is getting reduced. The initial part of expiration only will get slowed, whereas the forced vital capacity remains normal. So as a result, what happens? FEV1 by FVC ratio gets reduced. So FEV1 is reduced, whereas FVC is normal. So see, 90%, more than 80% is considered as normal. So FEV1 by FVC ratio reduces. In bronchial asthma, the ratio is reduced less than 80%. In COPD, the ratio is reduced less than 70%. Now, how will you differentiate bronchial asthma versus COPD? In both, FEV1 by FVC ratio is low. In bronchial asthma, the important factor is bronchodilator reversibility. Here we give a bronchodilator nebulization, for example, salbutamol or levosalbutamol nebulization. So following this, what happens is the FEV1 value will increase. So that is what is given here. So they are given FEV1 before nebulization was 35%. After nebulization or bronchodilator, it was 75%. So they say if the post bronchodilator there is 20% increase in FEV1, it means bronchodilator reversibility is present. It is present in bronchial asthma. Whereas in COPD, this bronchodilator reversibility is not present. See, it was 35% before nebulization. It is only 38% post nebulization. So this is how you differentiate the low FEV1 by FVC ratio in bronchial asthma versus COPD. Now, how will you differentiate intrinsic restriction versus extrinsic restriction? So I told FEV1 by FVC ratio will be normal. The ratio is normal, but both FEV1 and FVC is reduced. In intrinsic restriction, what is the thing? The lung itself is shrunken. So the total lung capacity will be low. Okay. Now what happens when restriction due to chest wall abnormality? When it is due to a chest wall abnormality, we do not expect the total lung capacity to be that much affected, right? So the residual volume and total lung capacity will be nearly normal. It's nearly the same in respiratory muscle weakness. So in intrinsic restriction, total lung capacity and residual volume will be low. In restriction due to external diseases, this total lung capacity and residual volume are nearly spat. There is a way to differentiate between chest wall abnormality and respiratory muscle weakness also. That is by looking at functional residual capacity. But at least it is enough if you remember intrinsic versus extrinsic restriction. Okay. There is another way to differentiate also by seeing the DLCO. DLCO is diffusion capacity of carbon monoxide. Carbon monoxide is a gas. When it is radio labeled and given, it should diffuse through the respiratory membrane. In intrinsic restrictive diseases, there is a problem with the lung, there is a problem with the respiratory membrane. So the diffusion capacity of carbon monoxide will be reduced. Whereas in extrinsic diseases, it will be normal. Okay? Nearly normal. So this is how you differentiate intrinsic restriction versus extrinsic restriction. In intrinsic disease, TLC and residual volume will be low. DLCO also will be low. In extrinsic diseases, TLC and residual volume will be normal, and DLCO also will be normal. Now obstruction, just an added point. In bronchial asthma, because nitric oxide is one pathology in bronchial asthma, this will cause increased DLCO. Right? In emphysema, there is destruction of the airway, so there is reduced DLCO. So these are some clinical examples for obstruction versus restrictive disease. Now these are some of the tough to remember concepts, right? The symptom analysis, then the lung volumes, capacities, shunt versus concepts. So now we will discuss about individual diseases in short. So bronchial asthma. So as discussed, bronchial asthma is an airway disease. So for all airway diseases, FEV1 by FVC is reduced. How much reduced? Less than 80%. Now how will you differentiate it from COPD? By doing bronchodilator reversibility. How much reversal should be there? 20% reversibility should be there. What is cardiac asthma? Bronchial asthma is usually occurring in young people without comorbidities. Cardiac asthma usually occurs in older people who has a history of or probability of heart failure. Like they may be diabetic, hypertensive, they may have history of cardiac disease. There is usually paroxysmal nocturnal dyspnea, right? So breathing difficulty in the night may be due to bronchial asthma exacerbation, or it may be due to cardiac asthma. So think about the possibility before you decide. So these are just the risk factors for bronchial asthma. Remember the word allergen exposure. We'll discuss about the pathology again shortly. There are two types of asthma, Th2 related and non-Th2 related. So allergen exposure is the main thing. So this allergen will sensitize the individual. Next time when they are exposed to the same allergen, some reactions occur in the body. One of the reactions is bronchoconstriction. Occupational exposure. Example, there is a disease called as byssinosis. Byssinosis is one of the occupational lung disease to cotton dust. So on exposure to cotton dust, what happens? It will cause a allergic reaction. So bronchospasm will be there. This leads to bronchial asthma. This is one of the triggering factors. Air pollution, some infections like viral and mycoplasma, tobacco. Tobacco is mainly associated with smoking, COPD, but it can also occur here. Remember the word obesity. Bronchial asthma usually will be obese, COPD will be lean, because in COPD there will be cachexia. Fungi in allergic airway mycosis. So fungus is Aspergillus. Aspergillus is a fungus which is commonly present in the environment. So it presents as spores. When the spores are inhaled, they can cause germination and it can become fungal filaments. They can cause allergic reaction. Usually Aspergillus causes some 3 to 4 diseases. We must remember three important diseases. One is called as ABPA. ABPA is allergic bronchopulmonary aspergillosis. Next we have aspergilloma. The next disease is invasive aspergillosis. So what is the difference between all of that? Allergic bronchopulmonary. Allergy, as we discussed, there should be sensitization. So when the spores or the filaments of Aspergillus are exposed, some sensitization occurs in the body. Next time when the same allergen is exposed, we get a hypersensitivity reaction. So that presents like bronchial asthma. So the presentation will be wheeze. Remember, bronchial asthma is an airway disease, so there will be wheeze. So one of the differential diagnoses for bronchial asthma is we have to rule out allergic bronchopulmonary aspergillosis. This is one disease where eosinophils will be high. IG levels will be high. Aspergillus specific IgE levels will be high. So this Aspergillus specific IgE is the investigation of choice in ABPA. If you do an imaging, we'll get something called as gloved hand appearance. like there will be mucus in the airways. Mucus in the airways looks like hand in glove. Aspergilloma is the presence of fungal ball. The fungal filaments form a ball-like structure and they are present in cavity. So, to say aspergilloma, there should be a pre-existing cavity. The pre-existing cavity can occur due to any lung disease. The commonest disease causing a lung cavity is, as we know, it is tuberculosis. So, a tuberculous cavity, that will have a fungal ball. So, the famous Monod sign in X-ray is due to aspergilloma. Invasive aspergillosis occurs in immunocompromised patients. As the name suggests, due to immunosuppression, this aspergillus fungus invades the tissues. So when it keeps on invading, assume that this is the fungus, due to invasion there will be a halo around it. So there will be a halo sign in X-ray or CT. Or there is something called as air crescent sign. Okay, so ABPA, allergic bronchopulmonary aspergillosis, is an allergic reaction to aspergillus. Aspergilloma is the fungal ball which is present in a pre-existing cavity. Invasive aspergillosis occurs in immunocompromised patients. Right. There is something called exercise-induced asthma. There is something called aspirin-induced asthma. It's called a SAMTERS trial. So what we must remember is there is something called type 2 Th2 response and non-Th2 response. So allergen exposure is the most common. We have occupational exposure, aspergillosis. Remember, one autoimmune disease causes bronchial asthma, Church-Strauss syndrome. Church-Strauss syndrome. The latest term for Church-Strauss syndrome is eosinophilic granulomatosis with polyangiitis. So it is one disease where eosinophilia comes. We'll discuss eosinophilic diseases shortly. So quickly about the pathogenesis. There is mucus production, airway edema, cellular infiltration, and vascular proliferation. So main thing is it's an airway reaction. So you can see compared to this side, there is smooth muscle hypertrophy, there is epithelial proliferation, there is more of mucus secretion. This occludes the lumen. The same thing occurs in COPD also, but the most important thing is there is reversibility. This can be reversed. So this is the one I was telling, the pathogenesis. There are two types of asthma, type 2 inflammation and non-type 2 inflammation. See the mediators, that is what is important. Type 2 inflammation, definitely there is a allergen exposure. So some allergen exposure is there, some sensitization is there. What are the mediators of the sensitization is something which we learned in immunology and microbiology. The mast cells. So mast cells degranulate and they release histamine. So histaminase enzyme is produced by eosinophils. So eosinophils also come into play, right? So the mast cells, histamine, eosinophils, presence of leukotrienes, and think of the mediators, interleukin 4 and interleukin 5. So interleukin 4 are cytokines which induce B cells to produce eosinophils, okay? So interleukin 4, interleukin 5, mast cell, eosinophils, these are the cells which come in type 2 inflammation. This is easily treatable because there are multiple options to target. Non-type 2 inflammation is not due to allergens or antigens, it's due to irritants and viruses. So this is called non-atopic. Here see the mediators are different. There is no eosinophil here, okay. There is no interleukin 4 or 5. It is completely different. So this is difficult to treat. So this is the treatment which is given in the 2026 GINA guidelines. GINA is an association which publishes guidelines on asthma. Similarly, we have GOLD, which is an association which publishes guidelines on COPD. So understanding the concept is very simple. So already when we discussed, there are so many cytokines which come into play. Okay. So we have type 2 inflammation and non-type 2 inflammation. Usually in type 2 inflammation we have eosinophils, IgE, many interleukins are produced. Most of this will respond to steroids. But steroids are not usually given in oral form, they are given in inhaled form. So we have a pathology addressing drug or pathology changing drug, that is ICS, inhaled corticosteroids. So this is called as controller because it controls the pathology. But we have another drug class which is called as reliever. It only relieves the symptoms but it doesn't change the pathology. These are the bronchodilators. So when discussing bronchodilators, they have of different categories: SABA, LABA, SAMA and LAMA. SAMA is short-acting beta agonist. LAMA is long-acting beta agonist. SAMA is short-acting muscarinic antagonist. LAMA is long-acting muscarinic antagonist. So beta is a receptor for sympathetic. So these are sympathetic agonist. Why agonist? Sympathetic system causes bronchodilation. So sympathetic agonist acts on the beta 2 receptors in the lung. Okay, don't forget it is beta 2 receptors in the lung. There are two lungs, so beta 2 receptor. There is one heart has beta 1 receptor. Now SAMA is short-acting muscarinic antagonist. The function of muscarinic or cholinergic system or parasympathetic system is to cause bronchoconstriction. So when we oppose the action muscarinic antagonist, so the receptor here is M1 antagonist. So when we give muscarinic antagonist, there will be bronchodilation. So in that, based on the duration of action, we have short-acting, long-acting beta agonist or muscarinic antagonist. So I'll tell few examples for SABA, LABA, SAMA and LAMA. SABA, the classical example is salbutamol or albuterol, terbutaline, etc. Long-acting beta agonists we have formoterol. Okay. Salmeterol. Formoterol is long-acting. At the same time, it is quick to act. It starts to act early. Salmeterol is long-acting, but it takes some time to act. In SAMA, we have ipratropium. Atropine derivative ipratropium. Long-acting muscarinic antagonists, we have tiotropium. Of course, we have other drugs also. Glycopyrronium, umeclinium. Okay. So these are the bronchodilators, short-acting and long-acting. In bronchial asthma, beta agonists have a very important relieving role. They act on the larger airways preferably. Muscarinic antagonists act on the shorter airways preferably. Smaller airways. Okay. So I told ICS is the first step. So in whatever asthma, because asthma is classified in many ways. It is classified as intermittent asthma, persistent asthma. Persistence can be mild persistent, moderate persistent, severe persistent based on the frequency of symptom. Like frequent night symptoms will be severe persistent. Okay, presence of any night symptom is called as persistent. But in a simple way, you assess the patient. If the patient is having asthma, occasional attacks, what we have to start initially is a controller plus a reliever combination, that is ICS plus SABA. So that is what is given here. So as needed, low dose inhaled corticosteroids are formoterol as needed. But when as needed formulations fail, patient is having persistent symptoms, we have to give it regularly. So always you have to use. That is called maintenance ICS formoterol. That is called as MART. MART is nothing but maintenance and reliever therapy. So initial step will be as needed ICS plus SABA. Suppose that is not responding or the patient is having persistent symptoms, we have to give MART, maintenance and reliever therapy with the same combination. Suppose that fails, we have to do increase the dose. So initially we are giving low dose inhaled corticosteroids. Then we have to give medium dose inhaled corticosteroids. Suppose all this fails, in the last step only we have so many other options, right? Like oral steroids. We have other oral bronchodilators like derifulin. And all the special drugs. So I told you interleukin 4, interleukin 5, IgE all play a role. We have IgE antagonist. That is omalizumab. It is a monoclonal antibody. It's an injection, costly injection. We have interleukin 4 antagonist, dupilumab. We have interleukin 5 targeting drugs, reslisumab, mepolizumab. So that completes the basics about bronchial asthma. I'll tell the name of inhaled corticosteroids: beclomethasone, budesonide, fluticasone. Okay. So hypersensitivity pneumonitis. This is traditionally a part of interstitial lung disease only, because this affects the lung, not the airway. But why we are discussing this along with the airway diseases, the mechanism is similar to that of bronchial asthma. So there is an antigen or an allergen exposure. The patient gets sensitized. Next time they get exposed to the same thing, they'll get allergic reaction. So since it is pneumonitis, there's an involvement of the lung. So apart from these, where there is airway involvement associated, here there can be cough, expectoration, etc. And there are actually lung signs. So this is one of the differential diagnosis for interstitial lung disease. So usually the fancy names will be asked. Farmer's lung. So there is exposure to thermophilic actinomyces, see the name. And bagasosis is sugarcane due to the thermophilic fungus. You can remember malt worker's lung, where there is exposure to barley. Bird fancier's lung, where bird feathers, droppings, right? So there are many. At least remember a few things. Either occupational exposure to some dust or bird organic things. Anything can cause hypersensitivity pneumonitis. So treatment is with steroids only.